in nursing. So she's working currently at Moi University and Teaching Hospital, Kenya. So her experience in clinical teaching and learning as an advocate of lifelong learning for quality healthcare, neuroscience, nursing research in traumatic brain injury, also stroke, seizures, and infectious diseases. In terms of experience, Sila, as a clinical governance manager, has a substantial experience in clinical policy and procedure development, implementation, and evaluation to assure patient safety. Actually, she's doing almost a lot of issues concerning with publications and so forth. So her daily working entires assessment, planning, implementation, and evaluation of nursing competencies. Also, she is a researcher with varying interest in traumatic brain injury and infectious diseases. As part of the study, different studies have been concerned with that area. So Faith is an adjunct lecturer at Moi University School of Nursing and Moi Teaching and Referral Hospital, as we have said, College of Medicine, where she teaches applied neuroanatomy and also neurosciences nursing. Also, she serves as a Nursing Council of Kenya administrator for her hospital and co-leads the academic model providing access to healthcare, so nursing working groups. So most important, she delivers direct patient care to critical ill patients across her hospital as part of rapid response team. And also, she has done a lot of publications and also presentations. So Faith Sila in this area has 6 publications and peer-reviewed journals and over 12 presentations in national and international conference, including the International Council of Nurses, ICN. So this is the second moderator that we have today on board. And the last one, on the part of presenters, we have 2 presenters today. The first presenter is Walter Milans. This one is a Tanzanian academic and healthcare professional, currently head of nursing management and education at the University of Dodoma, with a PhD in health sciences. His research focuses on adolescent sexual health, cancer screening, antenatal care, nursing education, and public health. This is a seasoned researcher and consultant. He has contributed in multiple health projects and peer-reviewed publications. So beyond academia, he trains peer educators So Mr. Safal holds a master's degree in critical care and trauma. Also, he's a PhD candidate from the Barcelona University and currently serving at the Mbeya Zonal Referral Hospital. So in addition to his clinical duties, he's a block manager at the surgical department, showcasing his exceptional leadership skills and dedications to patient care. So Mr. Safari is also the esteemed president of Tanzania Critical Care Associations, also reflecting his commitment to advancing critical care practices in the country. With over 15 years again of experience in providing top-notch nursing care services, he brings us a wealth of knowledge and experience to any settings. Furthermore, Mr. Safari has extensive experience in supervising and mentoring nursing students, specifically in the clinical area, but almost even the theoretical base at the different institutes. So including the intern nurses, ensuring the next generation of nurses are well equipped and proficient. His background in moderating and delivering training presentation is invaluable, making him an asset in educational and professional development context. So those are the presenters, but the last presenters will be Mofate team, where we have one of the areas that you want to share together as part of the team. So our timetable is like this. Almost we have like 7 areas to cover. So the first area will be the opening that you have been done currently until this time. And the second part, we are going to see now the insights into the training environment, where Dr. Walter Milans will be taking us through it. And after the presentations, we'll have a Q&A sessions for all participants. Here, Madam Sila and Dr. Bankania will chip on moderating the board on this Q&A session. And almost we'll go to clinical practice perspectives where Mr. Sixtu Safari will be presenting here. And after the presentations, again, we'll have a Q&A sessions for all participants. And here, again, Madam Faith Sila, together with Dr. Bankani, will be taking us through it. And also, we'll go for the last presentation that will be unveiling professional visibility through procedures that we are doing all the time. So here, Mofate team will present with the other expertise. And after that, we'll have 15 minutes for Q&A sessions, and almost will be long to closing. So this one also will be just taking part on a board by Faith Sila together with Dr. Bankania. So after such a small introductions, I would like to hear if those who have been introducing here, if they're here. Probably we can start with Dr. Milans. If you are here, please just say hi to us.
Hi.
Thank you very much. Thank you. You are most welcome. And also, we have Madam Sila Faith from Kenya. If you are here with us this time, can you just say hi to us? Madam Faith, if you are here. Okay, so she will be here with us. I think she's on the way to join us. So also we have on board Dr. Vincent Bankania, lecturer from UDOM, and Dr. Bankania, if you are here with us. Okay, I think he's here, but I think it's a problem of network. So he'll be with us again. So also on board, we have Mr. Sixtu Safari. If you are here with us, please say hi.
Hello.
Okay, thank you very much. You're welcome, Chief. And then we have Mofate team. I think they are here, all of them, but also the other experts where we have tried our level best to invite them. I think they are here. So without just letting a time, because we are out of the time based on the timetable, so I would like to take a chance now to welcome Dr. Walter to start his presentations for this evening. So Chief, you are welcome.
Okay, as I've been introduced, I am Dr. Walter, working at the University of Dodoma as a senior lecturer, but also head the Department of Nursing Management and Education. I think it's my pleasure to meet you guys in the umbrella of nursing profession. I know we are together and we are moving the move together towards the future. I think the future is now, yeah? So thank you very much for this opportunity, and may you please allow me to start sharing the insights that I have, which is almost based on my experience in nursing profession, but also in the teaching and learning arena in training institutions, both the middle and the higher training institutions. Yes. So as I've been assigned, it's just to share with you, discuss with you, exchange idea and conceptualization on how best can we build a nursing profession in the context of Tanzania, but penetrating to the global context, right? So it's all about how we as nurses can demonstrate autonomy and decision-making skills when we offer or deliver services to clients and patients in various settings, be it in the community level, but in the health facilities, right? Or wherever the environmental situation you are. So talking of autonomy, in the individual level, we say this is the capacity of an individual to decide something without any external influence or external factor that may command him or to do such an act, right? But when we talk of the discipline-based autonomy, we have a lot of it, yeah? If we are in the discipline of politics, we have political autonomy. But in our case, talking of nursing, means that we are dealing with the nursing autonomy, yeah? What is the global trend of nursing autonomy? How have we transited ourselves from the origin of nursing to now? Are we still having autonomy, or we don't have any autonomy when it comes to our discipline in a collaboration with other disciplines? So we need to evaluate ourselves in that context. So when we talk of nursing autonomy, I mean that is a capability of we as nurses, right, to demonstrate independence. Talking of how do we plan our care? How do we deliver our care and evaluate our care? To be originate within our nursing and not being informed by other or led by other people outside the nursing profession. So we have our framework on how to demonstrate autonomy. Yes. So this autonomy goes hand in hand with the decision making, right? Yes. See, how do we demonstrate decision making skills? Are we independent enough to demonstrate decision making skills, be it in the administrative part or managerial position, or in the technical, operational level? Those who are delivering direct care to patients, they're in the operational level. Are they competent enough? Are they able to demonstrate those decision-making skills when we decide to deliver care to patients? So these two terminologies goes together. They go together. And if we talk autonomy, it's directly we are talking of how people demonstrate decision-making, which are independent decision-making. Right. So this is the context that I'm going to share with you within the nursing profession. So I always, if I want to talk, discuss with the people, my claim, I always start with this statement of which you can think of it as professionals. And it is always used in a policy discipline, yeah? When you say not all people who drive motor vehicles are drivers, right? So you can have a lot of meaning from this phrase, yeah? But in real sense, it's true that not all people whom you see in the road over there outside, they are driving their motor vehicles. They are drivers. So, and then if we come to nursing, sometimes you can find that not all nurses who deliver care to patients, clients, they are nurses, right? It's not a good language, but we sometimes need to say the truth, you see. So what defines a good nurse or a good driver? Is the one who has undergone a comprehensive training program in a specified but approved training institution, which has been licensed to produce professional nurses. So that one who has been certified and licensed is a professional nurse and is allowed to deliver care to patients or clients. So we expect that the one who has completed these programs can be able to deliver comprehensive, professional, but science-based care to patients or clients. So I will pass you, I need to discuss with you the paradigm shift in health systems. At least we see how have we transferred ourselves from the past to the current. How is the paradigm shift in a healthcare system is in Tanzania as compared to other developed or developing countries? But we are going also to see at least the paradigm shift in nursing education, right? And at least to know the quality education and how this quality education is implemented in a training institution, be it middle or higher training institution. But the role of these training institutions to produce nurses who are autonomous and can make independent decision making when it comes to managerial activities or delivery of care, direct care to patients. Yeah. And then at least to share some challenges. Why are we stuck in somewhere? Why are we not moving to the pace of the 21st century as we are in now? Right. So paradigm shift in healthcare systems, right? I mean that when we talk of health discipline or healthcare system, we are talking of a number of disciplines over there. We can talk of nursing as we are, laboratory, pharmacy, medicine, whichever the health discipline that they are existing in our setting. Yeah. So these disciplines mean that they are developed independently. They have their programs where health workers are produced over there. And then in our case, nursing, it's a discipline, an independent discipline, right? But they are working under the umbrella of healthcare system. So it's a combination. The system has a combination of a number of disciplines, of which they work independently, but at some point they work collaboratively. And it's the patient or client only who pull them together. They meet together when there is a patient. But without a patient, it's hardly you can see them together. They work independently, formulating policies, strategies, frameworks on how best they can work to improve the well-being of people, right? So these disciplines, yeah, they have being independent mean that they are autonomous. They need not, if they stand by themselves, they need not to be contaminated by other disciplines. But if the situation requires them to meet together, it's where they can talk one language, a harmonized way of how they collaborate to facilitate the well-being of people, right? But if we separate them, they work independently. They decide by themselves, how should we go forward? How should we modulate this, modify this? How should we best make our strategic plan by 2030, right? These decisions are made independent. And then there are some points where they need to meet, collaborate, and share healthy perspectives or healthy concepts that intend to improve the well-being of people. So being autonomous means that you need to demonstrate professionalism, right? That is number one. Any professional that is standing as an independent profession need to demonstrate professionalism. And the professionalism, the indicator that this profession is demonstrating professionalism is its people should demonstrate competence, yeah, should demonstrate confidence when it comes to delivering quality, cost-effective care and unbiased care to people. But at some point, they need to collaborate. Autonomy, you get collaboration. And be it medicine or laboratory or pharmacy, they also depend. At some point, they become dependent. Right? They become dependent variable to other professions within the same discipline. So if it's medicine, there is a point that they will depend on nurses as an independent profession. Be it nursing, there is a point that through a patient, they might come to be dependent to medicine. They may come to be dependent to pharmacy, laboratory, whichever the discipline that is within the healthcare system, right? So that is how we can at least separate, define them independently when we say autonomous. Yeah, it's not full autonomous that we as nurses work alone. No, in a healthcare system, we need to work together. But all of this, we are fighting. At least each profession should fight by itself to demonstrate, to show, yes, evidence-based care, but quality care, ethical care, unbiased and cost-effective care, and sometimes cultural sensitive care, right? So that is at least the paradigm shift of healthcare system that we are now. And through this, if you are not good within your profession, identifying or having some understanding on these aspects, you can always quarrel with the other people from other disciplines, or you can quarrel among yourself within the same profession, right? So this has led to the paradigm shift in education. So talking of the education system of Tanzania, for example, we have a global trend from the beginning to now, which are driven by global trend, eruption of diseases, emergence of all of the issues that are occurring in the universe, contemporary societal demands, job market, they're all informing transformation in education system. So if the education system are affected by these global trends, mean that even the education system in nursing profession is also affected, right? So if you can remember, we were in the knowledge-based education system during the Nightingale era. And then we transited to competence-based education system, of which we are now. But we have our colleagues who have gone further to outcome-based education system. So outcome-based education system are those professionals that they develop their professionals to be able to deliver something from the education they have, right? So they are measured on outcome based. They are measured if they present, they showcase deliverables from what they've gained through a certain training. For instance, here we are sharing this knowledge. By the end of this session, each of us should demonstrate something which is a kind of a deliverable from this training. You cannot attend a training like this one and then you don't have any deliverable after completion of this training. That if we have that aspect or that in mind, mean that we are in the outcome-based education system. But currently we are in the competence-based education system where we need to master the steps. We need to master anything that should be done based on the principles that have been prescribed in the curriculum, whichever the guidelines that are existing, be it in the training institution or in the clinical setting. But we need to move to outcome-based education system where other disciplines have moved to there, right? Yes. So the education, the paradigm shift in education has led us, for those who are working in training institution, as you said, I'm going to share the insight how education system in training institution contribute to producing or developing autonomous nurses. So we are, or for any training institution to contribute, bear in mind that it should understand the kind of students who are applying and are registered or admitted in that particular training institution. So it's always adult learning, right? Be it in the middle or higher training institutions, adult learning. So teachers or instructors should always bear in mind how to define adult learning, So we have aspects to define them for you to position yourself to manage that student and manage to develop more having autonomous in nursing in our case. So you can define them based on the legal definition, where adult learner is almost above 18. Biologically, even in that, we receive students who are matured, whichever the aspect that you need to define who is adult learner. So that one is considered as very important when you want really to concentrate the developing a student, in our case, nursing student, who will be demonstrating autonomous and independent decision making when he is in the clinical setting. Right. So these are the aspects. Now, if you receive admitted students in your training institution, you need to understand the first. Training institutions are always encouraged to understand the nature, the characteristics of those newly administered, newly registered students in their particular training institution. These are independent. They are transiting from being independent. They expect it to be autonomous. That is number one expectation that they have. I'm going to study so that I have autonomous, a decision to decide by myself. But they need also to get result from the training. They are coming there not just to study. Some have purpose to come and study in your training institution. So we are conscious of that, and then we prepare strategies on how to handle them collaboratively and not independently. Yeah. So they have personal experience, and from their personal experience, they need to demonstrate something. Yes. So that is the concept of we are aware of who is an adult learner when it comes to training institution, middle and higher training institution. Yes. So the role of training institutions on this aspect now, talking of the nursing profession. Nursing profession by itself has been divided or classified into two aspects, into two classes. Yeah, nursing education. We have classroom level nursing education. It's where we are talking of training institution. Yeah, we're talking of UDOM, Muhasi, Bugando. Yeah, they are implementing. If it's in the classroom level, it's called the classroom level or classroom nursing education. So they have their roles on how to develop autonomous nurses right away from the training institutions. Right. And then we have a second class of nursing education in our case. It's called the nursing, clinical nursing education, where it has its characteristics, it has its curriculum, it has its human resource, non-human resources. And here we are talking of the health facilities, the community where students are sent for fieldwork, and even the research is falling within the clinical nursing education. So we as nurses, we need to understand that in nursing education, we are having two classes. And then these two classes, they need to work collaboratively. For us, of our professional organization to clear the theory practical gap, it's better if we understand that we have two classes of nursing education. And then these should match. What students are taught in the classroom level should reflect what is happening in the clinical level, in the community. And then if we have staff, of which we are calling them as clinical instructors, for example, if we know how to tally these two classes of nursing education, mean that if educators in the training institutions are oriented about what to teach and what to expect from students, they should also, the same should be also in the clinical instructors, mentors, whoever is working in the clinical setting to help the student develop knowledge, attitude, and the skills on how to deliver care to patients or clients. So these are the classes that you have in nursing, right? And then we are aware, training institutions should be aware on this so that we have a linear path of developing this kind of nurse student. So to implement this, we need control mechanisms, as I say. So for instance, we have international and national education moderators, right? Hexacon, whichever, the international organs that helps to moderate nursing education in the world. And then the aim is to make sure that the nurse who is produced or developed in Tanzania should work independently, professionally in the United States of America, for instance. Should be at one point one among the team kwenye msafara labda wa rais awepo nesi kutoka Tanzania, awe sehemu ya timu ya afya kwenye msafara fulani wa kiongozi, right? So if we are in that way, in that we are in the position to stand in front of people, in front of other disciplines, say that nursing is an independent profession because we demonstrate by actions. It's not by words, because autonomous is not coming by words. You can talk a lot, paragraphs and paragraphs, pages and pages, but nothing is demonstrated by actions. Now there is, you are not autonomous. But if you see other professions, they talk less, but they demonstrate more. That is independent profession. right? So we needed to know that one, so that we see if I am going to study at the University of Dodoma, you should be orienting yourself, yeah. Whom should I be after graduation, and what really am I going there to study? Am I going to start to be willing to be autonomousness, or is because nimekosa kazi zingine ndio niende nesa? If tuna screening tool ya kuscreen watu kwa intention zao za kujoin nursing, I'm sure that at one point of time we are going to get real autonomous nurses who are going to demonstrate independent decision making right away from the training institution, right? So we have those educational moderator who helps on how to manage nursing education internationalized, but in Tanzania. And in Tanzania we have internal education moderator, talking of NACTIVATE, NACTE, and TCU. These are internal education moderators that are supported or work hand by hand with the professional organizations. In Tanzania Bara, talking of TNMC, and Zanzibar, talking of ZNMC, I think. Yeah. So these are working together with the educational moderator to moderate the management of nursing education in Tanzania, so that we are able, the training institution are able to produce real autonomous nurses who will come in front to defend for the profession, but defend themselves, right? But we have also subject matters who are specialists, are always contributing to the prosperity of nursing education to produce autonomous and nurses who are capable of demonstrating decision-making skills when it comes to the managerial level or the level of care to patients. We have policies and guidelines, but we have emerging global trend also helps to modulate the management of nursing education so that we produce real autonomous nurses from the training institution. And the other stakeholders, yeah? We have stakeholders, talk of stakeholders, we have communities, society, students, and other education, nursing education stakeholders. Because there are people underwater, right? They pray for the nursing education to prosper, always, right? And then these are stakeholders that helps to modulate how best nursing education can be managed, facilitated in a various training institutions. So these are the classes and who helps to modulate nursing education. So we in training institution in general, they work towards implementing quality education. And then if this is the case, mean that in Tanzania, for example, taking an example for our country, and in nursing profession, we have pillars of quality education. I know that TCU has prescribed it to guide the training institution to adhere to it. A lot of guidelines have been developed, starting from who should maybe have training institution and how to go about the opening training institution. We have those guidelines in place. But the way, any of the way that you can talk, we have centralized education or curriculum programs, and we have decentralized curriculum or education in Tanzania when we talk of nursing. And those under the Ministry of Afya or Education, modulated by NACTE or NACTIVATE, they are called the centralized nursing programs or nursing curricula. And then there is a framework to modulate such kind of education. And it is prescribed that in order for you to train diploma students, you need to adhere to this framework. It's prescribed there, right? So who is prescribing? It's the one who determines which kind of a nurse should be produced under diploma. And if the training institution under centralized, they are developed based on the demand or need within the country. The one who is prescribing that kind of centralized curriculum is the one who determines Are these going to be autonomous, or they need to obey command from other disciplines or command from the central part, right? So if nurses are also part of developing centralized program or centralized curriculum, mean that we can be in a position to assure ourselves that nursing currently produce autonomous nurses. Otherwise, if we let others to decide for us, mean that this is called, in education, is called the pedagogy of the oppressed. Pedagogy of the oppressed means that you are nurses and you believe yourself that you are independent nurse because your profession is independent. But in the other side, in the managerial part, there is someone who is deciding on your behalf on what should you study, on what should you have to the graduation. Mean that if that is happening, we say that this is the pedagogy of the oppressed. You are allowing someone to decide for you while you are healthy enough, you are intellectually well, you are physically good, you are strong enough to defend, to stand for yourself, right? You are able to join even politics, to kwenda bungeni kusemea uuguzi. Maana yake ukimruhusu mtu akuamulie badala ya wewe mwenyewe, you are called, you are under the trap of pedagogy of the oppressed. Now we can ask ourselves, are we under this trap of pedagogy of the oppressed? And this is happening from the managerial level to the operational level, those who are doing delivering direct care to patients, right? That is centralized, yeah? And then we have decentralized. Decentralized are those that are independent training institutions. They are not under the control of centralized, talking of universities, right? Yeah, which are modulated by the TCU. These can decide what to deliver to students. How should the students who are admitted to this higher training institution should be developed, right? So I acknowledge that currently there is initiatives to find the harmonized way of harmonizing this situation. Yeah, the mismatch of students who are developed in a higher training institution versus students who are developed under centralized curriculum or programs that are in the central government, right? I know that there is those efforts so that there is harmonization. The student, talking of diploma especially, who are produced or developed in a higher training institution should be equivalent to those who are developed under centralized curriculum or program. So this framework has been introduced, and each level, each type of training institution should be aware of this one, so that if you know that you are belonging to centralized curriculum, there is prescription there where students are given, facilitators are given. So it's our role, it's the role of our managers to scrutinize, at least, see that the way they are produced, the way they are developed, are these going to be autonomous? Are these going to battle with the other disciplines when it comes to making decisions on patient's care?
Dr. Walter,
Right.
sorry for interrupting your time.
Yeah.
It's 47 minutes past 7. How many more minutes are you likely to take?
Yeah, I can finish it.
Thank you.
Right. So it's a conscious to this, and the initiative that is always done is to segment between vertical orientation of curriculum and the horizontal. So currently we are emphasizing horizontal type of curriculum organization, where a student nurse is exposed to a number of content from different disciplines, rather than typically content from nursing only. Yeah, so that is an emphasis to all training institutions, right? Yes. So I think others we can discuss as if someone has experienced whichever for discussion for the sake of time. But in really sense, this topic is very huge because it's the industry of producing nurses. We cannot talk about within 30 minutes only. So I can end up there to allow discussions and then be within time. Yes. Right. Thank you.
Thank you very much, Dr. Walter, for passionately discussing about how nurses gain autonomy through the training and the different ways in which that can be promoted in nursing education. We are so grateful for that discussion and how that autonomy is supposed to improve our independent functions as nurses, determine where we collaborate and where we depend. Thank you so much for that discussion. Any questions to Dr. Walter? I've not seen questions on the chat. Moses, are there any questions sent to your team?
That have been sent to our team. But just one thing to ask Dr. Walter Milanzi, based on his experience in terms of teaching, do you think in our institutes, based on the curriculums, actually the curriculum based on the presentation, it's like some of the issues, specific sensitive issues that can make young nurses even to define that they are autonomous while they are coming out from the training. But currently, what we see is like most of the products that are coming in in the practice from the institute or training institutes, they are always taking a time to make orders from the other professionals. And I think there is some of the mixtures of how we are collaborating in the health settings, because those products are coming from the institutes, specifically diploma level and even the higher levels. They always meet the orders, but they are not so much standing on their own, independent, based on what they have been learning in the institution. So what is the problems there? Are we teaching them something that even out from the things that they meet in the clinical area, or what is happening there? Because I think there is a clear gap of integrations from what they are learning in the class and what they are implementing in the clinical practice. So that is the area that I want Dr. Milanzi to speak something from there.
Okay, so thank you very much, Moses. Right, your concern is very genuine, and it's a nice question, and it's a practical also question, right? Yeah, because we observe it's happening now and then from decades. Yeah, it's a very minimal change, right? So this originates from the building blocks. We call them in education, nursing education. There is something called the building blocks of nursing education. And then this starts with the strategic plan, policies and the strategic plan. You see, our colleagues here, other disciplines in IFA, they have a strategic plan. By the end of 2030, we want to produce a nurse who is able to operate minor operative procedures. They make a strategic plan. And then from the strategic plan, which commonly originate from the policies I have, mean that they will guide and scrutinize all training institutions that are developed or are running to make sure that each program which is produced or developed tallies with the demand of the nursing profession, which responds to the contemporary societal needs. And then this, if you do like this one, mean that you can tally clinical nursing education and the classroom nursing education. We have this gap till to date. There is no a matching aspect between clinical nursing education and the nursing classroom level. So this is the problem, the major problem. And then the other problem to the human resources, right? Other disciplines, talking of the general education, for example, no one can teach nurses in a training institution without being trained in a very comprehensive program for him or her to graduate as a nurse educator, right? If we have that one, leaving aside those short courses, whichever the teaching and methodology short courses, these are the ones that also helps or contribute to the burden of why do we still develop nurses who are good in the classroom level, but they are not good in the clinical level. That this mismatch is part of the challenge in the building blocks of nursing education. So that is quality of those educators. Because if we are not from the program of nursing education, mean that we will teach the students in the classroom level or in the clinical the way you were taught also. Utamfundisha wewe ulivyofundishwa na wewe utamfundisha huyo hivyo hivyo, kwa sababu hujawa bado na competence za how to teach, right? That one is also contributing to we delaying somewhere, causing to the mismatch between theory and the practice. But also students' qualification. If we see the entry qualification of these students in nursing, right, determines the nature of a student, where they are going to be autonomous or not. So we are fighting, at least we have entry qualification of C, for instance, which is also applied to other disciplines. But I think previously, were all who are having D in higher education, yeah, secondary education, they were allowed to enter nursing, yeah. So nursing was a kind of a dump to receive anyone who has failed somewhere to come in nursing. But currently, I see the efforts to clear that one, so that at least even ourselves, we have pure. But also professional organization, I see their efforts to visit training institutions. They are now currently visiting training institutions to see what are they developing, what are they delivering to students, nurses, what are they implementing, what are the quality of this continues. Mean that we are going to clear this gap. So, but for now, we are still struggling in that stage, mismatch between clinical curriculum and classroom curriculum. But qualified nurse educators, yeah, the large proportion that you have, there are those with the short courses, for instance, right? And then those sometimes experienced, they are taken to teach students. We don't discourage that, but at least we mix it. Yeah, those who are experienced, but plus those who have undergone specified training. So we are struggling. I see the professional bodies, they are struggling to clear that one. Yes, Moses.
Thank you very much, Dr. Walter, for that comprehensive and very good response to that question. From your discussion, what I get is that there is still a lot of need to invest in clinical placement teaching, where the students go for their clinical practice during their training, so that they can integrate the theory learned in the classroom setting to the clinical skills that they need to obtain, so that they can be competent nurses upon graduation, that can be very autonomous in their practice. Thank you for that response. Any other question to Dr. Walter?
And maybe, sorry, to add this one, yeah? Sorry.
Yes, go ahead.
Experience from other places around the world, what they do to clear the mismatch is, if you have clinical instructors, for example, and you have academic staff, the way you treat academic staff, orienting academic staff to the curriculums, whichever the guidelines, clinical instructors also are invited to be oriented, so that they know what students are taught in the classroom level and what should be taught in the clinical level, so that there is similarity. And then also they are contributing to what is happening in the clinical area, which are updates. If they are meeting together, they discuss together, mean that they are also contributing something that is new to be introduced to the curriculum in the classroom level, so that the curriculum are updated of what is going in the clinical setting. That is experience from other areas. And then I think we have something to invest in, to make ourselves in that line, so that we talk a global language. Well, thank you.
Thank you for that response, Dr. Walter. I would like to ask, because I'm not very conversant with the training in Tanzania, do you have certain clinical skills lab training hours that the trainees must meet before they go to the clinical area?
Yeah, I think currently that is one among the improvement that are made in nursing in Tanzania through professional organizations. Yeah, for instance, TNMC, they're emphasizing and bolding the presence of clinical laboratory in each training institution, not the presence of clinical laboratory skills lab. You are talking about skills lab, yes, sorry. But quality skills laboratory, where students, after coming out from the class, they go to practice before even they went to clinical setting for touching real patients. So currently there are those improvements, and they are making efforts, recommendable efforts, because they are passing in each training institution to make sure that there is quality skills labs. So we have that currently.
I think that will be a very good step towards solving some of those mismatches, because it's through that skills lab training that they can demonstrate that competence, that mastery, that confidence to be able to perform in the actual clinical setting. Thank you for that response, Dr. Walter. If I could just share a short example in response to what Moses said, and what Walter has just explained. It's very beneficial if we could have the doctors, the professors that are teaching in the theoretical classrooms transition with these students to the clinical setting. This helps so much to fill that gap. I'll just give a typical example of my higher training, whereby the professor that taught me in class how to do advanced cardiovascular assessment is the same professor that sat through my clinical hours, ensured we have pre-conferences, in skills demonstrations in the real patient, and post-conferences. And that is very important, because your student feels so confident that what they've been taught is what is expected of them, with that real-time feedback from the same professors that taught you in class. I think that would be very beneficial.
And I think from your end, talking of professors, I can see an effort from Tanzania also to have at least professors within nursing, nurses who are professors, right? And having them enough means that our students will benefit much. That's why we are encouraging ourselves to advance our academic career. If we are in bachelor level, make sure that you go to master's level. And then if you are in master's level, come to PhD. And then later we have a lot of nurses with PhD, professor, and then your experience, I think one day we are going to have it in Tanzania, I think so. Right, you are good. Yeah.
Thank you so much. I've not seen, there's someone that's just posted something. I'm not sure I read it correctly, but I'll try to read it how it's written. Moses, I hope you are okay, so that I take the comment from Diaz. Is that okay, Moses?
Yes, it's okay,
comments
madam.
on the chat, so we can proceed. Thank you. So
yes,
what Diaz says on the chat is tatizo jingine ni conflict kati ya wauguzi wa zamani ambao wanaamini only katika kuaccomplish other professional order, na wauguzi wanazalishwa na modern nursing education ambayo lengo ni kuwafanya kuwa independent. How can we manage this situation ili kuipeleka taaluma mbele? Would you want to respond, Dr. Walter? I hope I read it correctly.
Yeah, I think yes, you have tried your best. Yeah, Swahili, yeah. So I've understood the question. Yes, it's there because I didn't share the challenges. I have challenges, and one among the challenges that make nursing to stagnate somewhere is a conflict within nursing. Yeah, and the conflict is the conflict of interest. Yeah, those who are feeling themselves that they have low education, they are fighting against those who are having higher education once they are introduced in the clinical setting. Yes, so it has happened. It is happening, this situation, and sometimes you can say it's one among the factors that make us to stagnate somewhere. So this depends. The answer is depends with the strategic plan of the profession itself, because each profession must have strategic plan, be it 5 years strategic plan or 10 years strategic plan. And then this should tally with the national strategic plan, right? Which is sometimes political. So nursing in Tanzania, is it having a strategic plan of transiting from which level to which level? That matters to clear that kind of conflict, right? If you are oriented or your target is to have a big number of diplomas, they are going to be powerful because in the system, few with higher education will be there, at least to say something which is evidence-based, right? So ukienda clinical wao watakwambia tu, yani huwezi kutuambia chochote kwa sababu kwanza wamepewa madaraka. They are given authority. They are head of departments, they are head of units, and then with your bachelor, you are not head of somewhere. It's very easy for you to be manipulated, right? And then even the care will be at that standard because they will not allow you to introduce higher level or have evidence-based practices because they say, yani wao wanajisikia inferior to your education, right? And I'm sure talking of our country through maybe professional unions, yeah, talking of TANA and the professional organization, I am sure they are fighting on this one because it's very visible. And then it's not visible only within nursing, it's visible even outside nursing because people are watching. They say, this program. Kwa hiyo kama inajizalaulisha. Kwa hiyo one is strategic plan. Make your profession have strategic plan. Be it 5 years. Tunataka muuguzi wa aina gani awe wa kwanza kuzaliwa baada ya miaka 5 ijayo. Muuguzi tunataka aanze level gani to fight wauguzi waende level ya masters. Hii itaondoka hii kitu. Emphasize vyuo vianzishe programs za masters kwa wingi kwenye nursing. Zianzishe PhD kwa wingi kwenye nursing. Hii itaondoka hii conflict. Kwa sababu tutakuwa na wa kutosha na nursing sasa itakuwa ni autonomous kweli. Sasa hivi education level inatulimit kuwa autonomous vya kutosha. Yes, so strategic plan and emphasize to increase advanced nursing programs in training institution. Itasaidia hii kitu kuondoka. Yes, thank you.
Thank you, Dr. Walter. I've seen some people had their hands on, but if you allow me at this moment to welcome Dr. Bankanie. I'm sorry if I don't pronounce your name correctly. Walter, thank you for teaching me a few Swahili words that I can use. If we could allow Dr. Bankanie to just give his remarks, he was the key moderator, and then have him welcome the next presenter in the interest of time. But I'm sure Dr. Walter will stay with us and we can take more questions after the next presenter. Thank you.
Okay, thank you.
Karibu Vincent.
Yeah, thank you very much. Very sorry for the challenge of internet where I am, so I've not been able to join with you earlier. Yeah, just a few remarks that I have, I would wish to share with you is, first of all, we should ask ourselves, who is a nurse? And what are exactly their roles in the clinical setting? And when we speak the autonomy of the nursing profession, are we speaking it in the clinical, outside clinical, or in all aspects? And what are the issues? What are the problems, the challenges in nursing autonomy? I remember I went somewhere. There are some nurses, even they do not know whether they are clinicians as well, for example. Some of them, especially the lower cadre nurses, they define themselves like clinical secretaries. And this is what it has been mentioned here. So I realized that we need, first of all, to understand what nursing is. The main role of the nurse in the clinical setting is monitoring of patient life, minute to minute, day, hour to hour, day to day. Second, to make sure that the nurse assess and meets the needs of the patient on the bedside. because the patient in the hospital having the needs unmet, you can do any other thing. You can treat whatever you treat. The patient will not come up. So I think there is a need for nurses to understand, first of all, what are their role at the clinical settings? What are they supposed to do? That's the challenge. But also, there is a very serious gap between what people are being taught in class vis-a-vis what they practice in clinical. This gap is affected by several factors. One of the factors is we have educated very advanced nurses in the teaching institutions, but you have very lower cadre nurses working in the clinical. This creates a very big difference in their knowledge gap, and they cannot even translate what is being taught in class to what they are supposed to give to students. So that becomes a big challenge. And me as a lecturer in the Department of Clinical Nursing, I have faced one of the serious challenges. You teach students the practices of what they're supposed to do in clinical, but when they go to clinical, the exposure, they meet a different way of practice and they adapt to what is being practiced in clinical than what you taught them in class. So that is a very big challenge. Another issue which I see is, does the clinical environment allow nurses to practice autonomously? Nurses work in collaboration with other professionals. Do they really understand what is nursing and what is not nursing? Because most of the people who are in the administrative positions are non-nurses, and they have their false perception against nursing, and most of them would not allow the practice of nursing autonomy on the bedside. Taking, for example, the issue even of documentation of nursing activity. I see some of the hospitals, you go there when they just document properly. They are told that the resources are not for nursing documentation. Nurses are just there to practice and not documenting. So those are the challenges. Those people who work collaboratively with the nurses should also understand what are the scope of practices among different cadres of nursing. Another small issue as I finish is on the paradigm shift. Most of the sub-Saharan African nursing practice do not operate under the holistic model. They operate under the medical model of healthcare delivery. So when you are working outside the holistic model, you are unlikely to be able to demonstrate, to exercise autonomy, because the medical model is principally medical oriented and not holistic oriented. So those are the challenges which I think they need to be addressed before we have our profession fully autonomous. Thank you very much. This was my little contribution on the matter.
Okay, thank you very much. Madam Sila, Faith, if you are here, maybe we can invite the second presenter, Mr. Six Safari, and then we will chip on with the next questions and responses. So if Madam Faith Sila, you are here. Or Dr. Bankania, you can invite even the second presenter to continue.
Thank you very much. Maybe you can take this opportunity now to welcome the second presenter for the next presentation. Then we will have some opportunity for questions at the end, question discussion at the end. Mr. Safari, warmly welcome. We hope we are together.
Yes, Dr. Bankane, good evening to you all.
Good evening.
Good evening.
Could you please share my presentation?
Yes, I'm just opening here.
Okay. Okay, thank you. As I've been introduced, my name is Sixtus. I'm a critical care nurse specialist. I work at Mbeya Zone Referral Hospital as the head of the intensive care unit and also the president of the Tanzania Critical Care Nurses Association. Next. Now, I would like to present or discuss with you about the multifaceted role of the clinical nurse in the clinical setting, what to expect from them, discuss various roles they play in the healthcare system, from being an independent decision maker in a clinical setting, and also to become a profession joined, or you can call it multidisciplinary networking during in a clinical practice. So you may ask in a clinical setting, what does the nurse possess or should have, rather than being prescribed medication? There's a lot of things we nurses possess in a clinical setting, especially when we are dealing with our clients. For example, nurses should exhibit professional knowledge, should exhibit communication skills when attending their clients. So by doing so, the nurse should establish a therapeutic relationship with the client by providing education and support. At the same time, ensuring the patient or the client is actively involved in the care plan. So the communication could be verbal, could be non-verbal communication, and this should be involved, accompanied by active listening to the client's concern or relatives, and they also set, can say, clear expectation of the procedure to be conducted, explaining sub-diagnosis which the patient has possessed, also the treatment option which should be in place. Second, the nurse should have respect their clients by maintaining professional demeanor, by taking confidentiality seriously when dealing with their clients, and keep patients' wishes at the forefront of the treatment. Also, clinical nurse should possess organizational skills because this is very important, especially when paying close attention to the patient details and continuous monitoring and documenting what has been observed. That's called the vital signs, any change in the patient condition, of which that nurse can either independently act upon, I will discuss that later, or can share with others, healthcare team like doctors, for the immediate intervention. Also, nurses should possess empathy by maintaining professional boundaries during their clinical practice. Next. Okay. So the backward, the independent role. I'll talk about, for example, when we talk about clinical assessment, for example, we do clinical assessment to our clients in terms of assessing their conditions. We do so by gathering subjective and objective data or information about our clients so that we can understand their overall condition and their needs. So this process usually involves evidence-based practice or using evidence-based tools. So subjective data, for example, we gather is they include the patient's own accounts of their experience, feelings, what they perceive, the experience with the pain they're having, any symptom they possess or they have their concerns. With regard to objective data, this includes like gathering information through via observation, physical examination, do various tests so that we can rule out what is really happening to the patient. But also, I can give an example with an independent intervention the nurse can process. For example, we all know aware of something called vital sign directed therapy. These are guidelines which are made guide nurses to provide rapid intervention when the patient is in a critical state based on the vital signs they present, which are maybe the heart rate, the respiration, oxygen saturation, for example, the blood pressure, the temperature, etc. So this guideline helps the nurse identify and address abnormal vital signs, which may lead to potentially harm the patient or make the patient deteriorate, and also improve the patient outcome. This can be implemented by nurse without any assistance from other professionals like doctors. And it's simple. It's a vital sign focused. We use color code. For example, normal, green means normal, yellow means abnormal, and red means the patient is in a deteriorating state or in danger state. So that's about the independence. When we talk about dependence role in clinical practice, we are talking about prescribing, administering prescribed medication by doctors, or during surgical intervention, assisting in theater on bedside procedures done by doctors, or even managing a patient who is on mechanical ventilation. Next. Something happened. Can't see my slides. Okay. But also at the same time, we collaborate with other healthcare team. Next. Next. Can you hear me? Hello?
Moses, kindly advance the slides.
I will proceed. So we talked about being independent and dependent. Now let's discuss a little bit about the collaborative role of the nurse. This can be observed during maybe multidisciplinary round, almost disciplinary team approach, especially not rounding per se, but also during family conference where we involve other healthcare personnel. But a good example is during a rounding where various healthcare personnel team, that is nurses, doctors, pharmacists, therapists, counselors, they're involved in discussing various issues with the patient with regard to the patient condition. So in this part, that a nurse plays a significant role during this multidisciplinary rounding. But also, we collaborate with others by coordinating patient care with other team, as I've mentioned. But also, we collaborate when making a decision for the patient's sake with the doctors and the other healthcare team who are involved in the care process of the certain patient. I would like to discuss something about the importance of having both, being independent as a nurse, being independent to others, and collaborating with other healthcare team. It's very important because it ensures a comprehensive patient care. So a nurse should balance, depending on the situation the nurse is in, being independent. For example, I gave an example of the vital sign directed therapy. You are in ICU or in emergency medicine, the patient changes, there is increased heart rate, the patient is sweating, airway is compromised, you need to secure airway, you need to give to administer oxygen to the patient. That's being independent as a clinical nurse practitioner. But also providing medication and the other care directed by the doctors or the multidisciplinary team after the long discussion about the patient condition. That's dependent. But when we collaborate with others, like surgical team or other healthcare team, especially, for example, I give an example of the multidisciplinary rounding, our interdepartmental collaboration, that's collaborative. So with this, it enhances patient satisfaction, better healthcare outcome, and improve team efficiency. So in order for the nurse to exhibit, or to process, not to exhibit, to process those mentioned being either independent, dependence, and being collaborative with the team, it requires a continuous improvement in education, whether on site, like in a hospital setting, or formal education, like in the universities. So there is a need to have advanced practice education for nurse practitioner. The previous presenter was talking about having more master's students, PhD students, and the professors in nursing profession. So it's important, and it can improve our working condition. Ethics are important. There is ethical implication in clinical practice. The nurse must navigate ethical challenges when balancing their autonomy with others. Advocating patient needs. Is very important. How? So a nurse plays an important role, especially when advocating the clients or patient needs. Also by serving, let's say, a bridge between the patient and the healthcare team. Also at the same time ensuring the patient's rights are protected and providing a voice for those who may be unable to communicate their needs. Also, family members may have also concern about the patient needs. So This can be done by providing education to the patients and their relatives and making sure you help them understand the condition and treatment in hand, and that the procedure, if there is any procedure planned for their clients, the pros and the cons which may occur to the patients. In clinical practice, we have some challenges, especially whether we are working alone or in collaboration with others. For example, the role of confusion among nurses, usually characterized by unclear responsibilities and expectations. This one can stem from unclear role definitions or overlapping duties with other healthcare professionals and lack of clear communication among we nurses or other healthcare professionals. My apologies, you might hear some noises. It's raining here, so I don't know how to make the noise go away. So another example is increased workload, the ineffective nurse-patient ratio, I think the ability of the nurse to engage in all roles. We have seen in many settings nowadays, we have a huge shortage of nurse-patient ratio. You find a nurse in the ward, have 32 patients, and he's just alone in the ward, which may be difficult for that nurse to perform his or her duty effectively. Strategies to improve, they may include clear role delineation in healthcare team, or advancing for adequate nurse staffing and support, and also more training, and also in interprofessional communication skills, among others. So the nurse ability to become independent or dependent and also become collaborative role leads to holistic patient care, patient-centered care. Also, strong teamwork and oral flexibility can improve healthcare delivery, reduce medical errors, and promote continuity of care. A well-integrated nursing role can help reduce hospital admissions, streamline care delivery, and promote preventive healthcare measures. So I can summarize what have been discussed, that the nurse holds a crucial role in healthcare. A nurse can be independent in various clinical practice. Also, she should be familiar with being independent to other clinical, to other team, like doctors, but also able to engage with other healthcare team in terms of collaboration. A clinical nurse, they have contribution. Their contribution is essential for ensuring high quality of comprehensive care across a diverse healthcare setting. A clinical nurse should balance these roles, like I said, depending on the situation, and this, by balancing being independent, dependent, and collaboration, will enhance and improve patient outcome and the healthcare system effectively. So the final thought could be continuous professional development and interprofessional collaboration are key to maximizing the impact of nursing role in the healthcare system. Thank you so much.
Yeah, thank you very much for the nice presentation. And maybe would wish to just start hearing questions from people. In fact, you have presented very well and shared some of the very important issues. However, I always fear when I'm addressing a nurse, I always fear to present a nurse as a passive person. There are terms that we have to discuss more, whether they are appropriately to be used or not. The issue like directed by the doctor. Nurses do not work according to the doctor's direction. These are two professions. We have the medical profession, we have the nursing profession. They are interdependent. When a doctor diagnoses a patient and writes a prescription, that is the medical aspect. That is medicine. When a nurse administers medication, that is nursing part of it. So, you know, it is like nursing and medicine is like architectural engineering and civil engineering. An architectural engineer prepares a draft. A civil engineer translates the draft into reality. So nobody works by being directed from another, unless if what the architecture is performing is of civil engineers, then he will work under the direction of the civil engineers. But otherwise, these are independent professions, and each of the persons contribute to the outcomes of the patient using their independent knowledges. So I think we should best be emphasizing those types of terminologies to make sure nurses actually understand their active role in making sure that they contribute enough. Otherwise, we should also understand and remember that nursing profession, if performed well by a nurse, a professional nurse, can contribute between 30 to 70% of the patient well-being from hospital, nursing alone. So that is something that should also be very clearly addressed to nurses as well. Also, nurses should be guided by the scope of nursing practice that is stipulated independently what the nurse should be doing. Actually, the Tanzania Nursing Midwifery Council is the scope of practice that has stipulated everything, and nowhere it says that nurses work under the direction of somebody. No, they are working according to their profession. So with those few remarks, let me welcome some questions from the members. Welcome. Welcome, members, for questions. Sorry, Mr. Moses. Mr. Moses, or my fellow moderator may continue a bit. I see some challenges in network here again, so I may not be able to.
Hello, Chief.
Yes. Maybe you can moderate this, because
I have a question to. Yes, I have a question to Mr. Sextus. Can you hear me?
Yes, yes.
All right. So my question goes to you, Mr. Sixtus. Nowadays, we see some of the institutes, they receive new nurses, but they are not doing orientation package, or they are not doing inductions. So most of nurses now, they are lacking some sort of knowledge based on the scope of practice and the issue that they have to stay with it. And you'll find in the hospital, they are now staying with the, something called pulse sharing. which allow them to do a lot of activities, sometimes even goes beyond their scope of practice. And I think this is one of the challenge. So who is responsible? And they induce them the principles and all the issues concerning with the professions around the clinical practice setting. Who is responsible? Because I think this is one of the challenge.
Yes.
Thank you.
Thank you, Mr. Moses, Mr. President. This is a very big challenge in a clinical setting. And if the nurse during her internship did not do well for that 1 year, we face this kind of challenges on our daily practice. And I believe it's a sole responsibility of the institution to orient these nurses instead of showing them in clinical areas when they don't know institutional policies, how are they supposed to practice. So in our setting, what we do, because we know that is a very big problem, we usually attach them to the seniors in their respective roster, their seniors, so that they can gain something. And with my experience, usually takes depends on kind of a person, usually takes between 3 up to 6 months to someone to catch up, especially in a critical area like intensive care or emergency medicine. So I truly believe it's a responsibility of the institution and should be put on the budget so that things can go smooth.
Thank you, Safari, for that response. Moses, you are still up.
If I have already subscribed.
Okay, thank you. Faraja, your hand is up. Kindly go ahead and ask your question.
Thank you. My name is Faraja Kilewa, and I'm a bedside nurse. Speaking from reality from our settings, we are failing to balance between the independent, collaborative, and dependent roles as has been stipulated by previous presenter. For example, the issues like nursing care plan, decisions to patients, like giving them health education or whatever it comes, most of them are not done by nurses. Even in my setting, they are not done. Except we as nurses, most of the time are focusing to do those tasks which are maybe dependent or collaborative. Like you can meet a nurse bees collecting samples or probably giving medications, but when it comes to doing those things that a nurse has to make decisions, few of us are doing. So I was having a question. How can we, what can we do to balance those roles, especially the independent ones? They are so simple. We are taught in our institutions when we are studying. The shortage of nurses in healthcare setting maybe, probably living such a reason as constant. What other ways can we do so that the independent roles of nurses can be brought forward and probably our profession can be seen or our roles can be seen? Thank you.
Safari, would you want to address that?
Yes. So I think it's a matter of knowing the clear role of a nurse, knowing your responsibility as a nurse. Where do you think you fit? What things can you do by yourself as a nurse, competently, professionally, ethically, by advocating the patient's rights? Or what other activities or duties or roles you may need to collaborate with others? So I think it's a matter of knowing you as a professional nurse, knowing where are your limits, what things you can do, of which you have been trained in a training institution, in a clinical practice. Those are within your capabilities, and those of which you are required to be helped by others or be instructed by others, and those of which you can share or collaborate within the multidisciplinary team. I think that's the best way you can do that.
Yeah, maybe in addition to that, for a small interference on the matter, the first and most important thing that I can also add to the good answer you've said is nurses should study hard and become knowledgeable on what they are supposed to do, because it is a bit challenging when you say you don't know what you can do independently. While we have books, we have everything, we have most of the knowledge is in the internet that gives us the direction, the instructions of what to do in a specific situation. For example, you are taking care of a patient who has a stroke, ischemic stroke, for example, and the doctor has prescribed medication, one of them being lowering blood pressure.
Sorry, Vincent, I think we've lost you. Okay, I think we've lost Vincent. Safari, with your permission, can I weigh in to the discussion?
Yes, please. I wanted to add something, maybe add on the previous question, which was directed to me. Maybe another way of explaining is that being independent role, it involves those you think you can be self-directed or can be self-implemented based on the nursing professionalism in clinical setting. For example, providing education for a patient. It doesn't require someone to come and help you. You can do it by yourself. Educating the client or relatives in the various settings. Simple. Administering oxygen. You don't need anyone to tell you to administer oxygen, because as you see the patient is desaturating, you know exactly that you need to give the patient oxygen therapy. The patient is unconscious, and you put the patient in supine position. You know one way or another the patient will aspirate. So if you're not able to secure the airway, at least put the patient in a lateral position. So those are things you can do as a nurse without any assistance of any other person. Thank you.
Thank you, Safari, for the response. Vincent, before you freezed on the screen, you were saying something. Would you want to talk about it?
Yeah, just to put it in short is, we nurses should be knowledgeable, and we should not underestimate knowledge. Always let us study hard. Whenever you are, for example, receiving a patient who is hypertensive, you should read what is the care of a patient with hypertension. or with the stroke, or with whatever the condition receive, and then translate the care into real practice. I was saying, for example, even the simple procedure of fluid infusion. The doctor has ordered fluid infusion to the patient. And you see this patient is hypertensive. On assessment, the patient is hypertensive. The doctor has ordered normal saline. Will you practice it? Will you administer normal saline to an hypertensive patient? Very unlikely. So it's you, nurse, to be able to reason, because at the end of the day, we should not forget that nurses are the final person who regulate everything that gets into the patient. So the nurse must be well knowledgeable to know exactly what this thing that enters to my patient is therapeutic or not. And he must be able to reason critically. Even during the infusion, you are infusing fluid. At the end of the day, you see the patient is getting getting breathing difficulties, for example. You should reason it out. You should auscultate the lungs to see infiltration. If the fluid is infiltrating, for example, the person may be experiencing circulatory overload and pulmonary edema, for example, secondary to the infusion. You should stop, even if the prescription says give this fluid for 4 hours. Now you see the patient is suffocating. Will you continue? This is what we call clinical reasoning. So nurses must be able to reason very critically when they are providing care on the bedside. I think that's what I wanted to insist. Even the last example on the ischemia, the patient with ischemic stroke and hypertension. You know, when you are taking care of a patient with ischemic stroke and hypertension, you know that blood pressure must be monitored to a certain level, a little bit higher, to allow blood supply to the brain. Now the doctor has just prescribed antihypertensive. Will you continue to administer while you see the blood pressure is dropped to 90/60? You continue while you know that by doing so, you further compromise blood supply to the brain. So this is what we call the clinical role of a nurse as an active professional. You should know, when I'm administering, how do I monitor the life of this patient? How do I monitor the complications? How do I monitor whatever is happening, whatever is challenging the therapeutic part of this medical and nursing intervention? This is the active role of the nurse that we address to nurses every day. Thank you very much. That's the little I wanted to emphasize.
Thank you, Vincent, and thank you, Safari, for the great discussions. I think it's a very interesting way of looking at the clinical role of the nurse and how we ensure that the dependent function of a nurse, the independent function of a nurse, and the interdependent or the collaborative function of a nurse are well executed. But if I could just summarize right from the beginning, where we talked about training, then talking about the actual clinical practice, what we need to always remember as nurses, what kind of delineates these roles or kind of guides us on which aspect do we ensure our independent function flourishes, which part will we need to depend on another profession, and which part do we collaborate, is based on some few key things that I would want to highlight. And first and foremost is the level of training of that nurse, because the level of training determines the competencies that this nurse possesses to be able to either function autonomously or independently, or to be able to depend on another profession, or to be collaborative. The other key thing that will determine how we play those roles is the scope of practice that you have been accredited to perform. That is very key. The other key thing that we always have to have at the back of our minds, that is very important for us to be able to play these roles quite well, is factoring in aspects of patient safety. Always ask yourself, after you do your nursing process, you have assessed your patient, you've made a nursing diagnosis, you've planned the care, and your priorities are correct. Then when you want to start intervening on your patient, you ask yourself, what can I independently and safely do to this patient that will make sure they do not deteriorate further or improve their likelihood of good outcomes? What is it that in the planned aspects I need to consult another discipline? What is it that I need to collaborate with another discipline to be able to execute? Those things are very important for us to bear in mind, because first and foremost, care that we give should be safe for the patient. So if you are a nurse and you're not accredited, or you're not, there's no approval from your regulatory body for you to prescribe, you cannot go ahead and prescribe, because if things go wrong, you are likely to risk the life of that patient. But if you're a nurse practitioner and you're allowed to prescribe, then the prescription in your care plan can come as a key intervention. But if you are not, then you would want to consider, for example, your patient who was in the ward had this seizure, they fell from the bed and they had a fall with an injury. For example, they've had a fracture following that injury. Your patient is in severe pain, acute pain, perhaps a score of 8 over 10. Then you'd want to ask yourself quickly as you plan your care as a nurse, what is the most important thing that I can do to at least help this patient feel better, improve the likelihood of good outcomes? Your key intervention that is immediate in that patient would be, the first and foremost thing is immobilize the limb that has had the fracture. It is a quick way of reducing the pain. Before you consult, if you cannot prescribe, get the medications and administer the medication, which is your independent function as a nurse of administering the medication. But if you're not a nurse practitioner, for the prescription, you might want to depend on your accredited prescribers in your institution. So you've got to weigh on those things, but you have to ensure that your practice is based on your level of training, your scope of practice that you are accredited to execute. How safe is the patient in your hands? Aspects of patient safety. But another key thing that we always have to remember as nurses is to have in mind, what are the hospital policies, the hospital protocols, the clinical practice guidelines telling us, dependent on that institution? To what level are we allowed as nurses to function in that institution? And that is the space we have to fight for as nurses, so that these clinical practice guidelines, these hospital policies and protocols enhance our autonomy as nurses to function. For example, you're having an hypotensive patient. The clinical practice guidelines or protocol, standard operating procedure in your institution should allow you as a nurse to start the infusion even as you wait for the doctor to come and review your patient as you continue to monitor. We need to fight for that space so that these policies and protocols or standard operating procedures kind of factor in the autonomy of us as nurses to function. That will be very, very important. But I would always advise, as you do your priorities in terms of plan of care, always prioritize what you can autonomously or independently do as a nurse, ensuring patient safety. Then the other things that are dependent and collaborative can come as the next of actions in terms of the care that you are offering to your patient. Thank you. We still have more questions on the chat. With the guidance of the rest of the team, do we still have time to respond?
Yeah, maybe before we let me chip in a bit in a few sentences. One is, let us be very clear when we are discussing about nursing and the role of nursing as a different profession from medicine. A nurse and a medical personnel, they all study pharmacology, but we differ in application. A medical doctor will use pharmacology to prescribe the medication. A nurse will use the pharmacology to administer medication. And remember, we have 10 errors that the nurse must go through before administering that single medication. That is the role of the nurse. So when we say a nurse consult a doctor, on which aspect? Because if you say, because when the doctor prescribes, that is medical part of it, is his responsibility. And my responsibility is on administration of the drug, using the 10 principles of drug administration. So that's now we have to be very, very clear. But also, according to the nursing scope of practice in Tanzania, handling emergency is the role of the nurse. And actually the TNMC is very serious on the matter. Mgonjwa anatapika, anaingia kwenye shock. Now we have seen these scenarios. Mgonjwa anatapika, ana intestinal obstruction, anaingia kwenye shock. Muuguzi wewe unapambana kupiga simu kumuita daktari badala ya kusave life, mgonjwa aingia kwenye hypotension. Hapo mzee unaliwa kichwa. So we have to be very careful. We should address a nurse as an active profession who practices according to his or her professional knowledge and practice. Now medical personnel are practice according to his or her scope. And then although these two professions, kuna area ambayo tunaweza kumingo. Kwa mfano, kuna some aspects ambao wauguzi wana prescribe, kwa mfano kwenye anesthesia na kwenye critical care au kwenye emergency, in life saving situation where you are the only personnel ambayo unaweza uka save life, you do that. But also you should not forget, in sub-Saharan Africa unakuwa na graduate nurse aliyosoma pharmacology ya degree, alafu daktari uliye naye ni CO ambaye ni form 4 failure, akasoma ka upgrade. Sasa huyu form 4 anapoandika dawa, wewe unasema mimi kazi yangu kwa administer. Ndio maana lazima science dominate. We believe huyu graduate nurse atakuwa na science ya juu kuliko huyu. Kwa hiyo huyu atafanya majukumu yake kama prescriber, lakini muuguzi lazima apitie critical, ndo zile 10 errors. One of the errors ni right reason for the drug administration. Kama dawa haiendani na ugonjwa, muuguzi huwezi kuadminister tu kwa mgonjwa kwa sababu imekuwa prescribed. Hapana. Hapo unapigwa penalty na leseni yako unanyang'anywa kabisa. Ni lazima ureason it out. Kama inapishana na knowledge yako, you consult science. If you see there is contradiction, don't administer what you think is not scientific. Consult yule ambaye ameprescribe, arudie. Ni sawa sana architectural, mtu ambaye amefanya architectural engineering, akishachola mchoro wa jengo akaweka hapo, civil engineer atakuja kuchukua ule mchoro, akiweka kwenye implementation, akaona kuna sehemu unakwama, atamrudishia architectural, bana hapa ulivyochora naona hapa huu mlango unatokezea chooni badala ya kutokezea chumbani. Kwa hiyo huu mchoro nataka kurekebishwa. Yule atarekebisha ule mchoro, atamrudishia tena civil ataendelea. Ndivyo jinsi ilivyo. These are the sciences that work independently but collaboratively. We should emphasize that ili wauguzi wajue kwamba they have the active role to play kuhakikisha mgonjwa anasimama. Hilo ni la muhimu sana. Sana. Asante sana, ni hilo tu.
Thank you, Vincent. Maximilian, your hand has been up for quite some time. Go ahead.
Okay, thank you very much, moderator and the presenters. Anyway, I have few comments. One is about the issue of task sharing. I think one of the very problematic aspects is this what we call task sharing. Most of nurses, if, for example, Dr. Bakade is a lecturer, if you do a small, interview of nurse students, especially the bachelor nurse students, they are there because of the boom and other issues, but in fact, they don't like nursing. And that's why you see, when you go to the practical area in the clinicals, you find most of nurses prefer doing medical procedures more than nursing procedures. When you go through the patients, you may find the patient is admitted, he's there almost a week, he has never been checked vital signs. And the nurses are there busy with medical issues or laboratory issues. So I think the issue is not that yani changamoto kubwa ninayoiona mimi ni kwamba most of nurses, they don't like nursing. Yani wapo kwa sababu walikosa pa kwenda. Kwa mfano siku moja I was teaching at St. John as a part-time lecturer. Wanafunzi wauguzi wa kiume wote, almost 75%, they were there because they missed to go for pharmacy or for for medicine. So these nurses, once they graduate, you don't expect anything from them. Muuguzi anafurahia akiitwa daktari kuliko akiitwa nurse. Je, unategemea atafanya majukumu ya uuguzi? Hii task sharing imeruhusu muuguzi kufanya issues other than nursing activities. Kwa mfano laboratory activities, unakuta muuguzi yuko busy kupima IPC kwa maana ya kupima HIV, kupima kaswende, lakini hayuko tayari kupima vital signs. So maana yake tuna wauguzi wasiopenda uuguzi and they are practicing nursing. And that's why even when you go through the most of nurses believe that we are there to help medical doctors. Kwamba ukitoa dawa, for example, as Dr. Bakene was saying, if you are administering medication, that is not alone, not that you are there to help the doctor. You are doing your own work. Je, wauguzi wangapi ambao wanajua kwamba kugawa dawa ni wajibu wao na sio kazi aliyoagizwa na daktari? A lot. Na hata sisi ambao tumehudhuria presentation, if you ask one after another, we have such kind of people who think they are there busy doing medical issues. And you may wonder when you go to a presentation or clinical meetings where there are nurses and doctors. Utashangaa unamuona nurse yuko busy, hata ripoti anayoandika ni ya daktari, aandiki ripoti ya nursing. So watu wamechukua wauguzi, they think medicine is the standard of health profession. Muuguzi anadhania kwamba anapokuwa kwa mfano maternity for example, kuna daktari mmoja gynecologist alituambia siku moja kwamba daktari anasoma ukunga for example for 3 months and the nurse goes almost a year studying midwifery. But you may wonder, the midwife is there at the labor ward and she faces or he faces the problem, obstetric one. He calls the clinician, clinicals to come and solve the issue of midwifery. Je, huyo ni muuguzi au ni bumuda tu limekaa somewhere? So tuna shida kwa wauguzi, wanadhani the issues of ya medicine yote inakuwa solved na daktari. Na ndio maana hata ukiwa na CA kwa maana ya clinical assistant, midwife ambaye ni professional, ana diploma na degree, atamuita CA kuja kumsaidia kutoa placenta. So you see, so actually we have a lot to solve. And I am very happy with this follow-up because we are trying to remove this kind of abnormal minds in our heads. So thank you very much. Nilikuwa nataka tukuchangia kidogo.
Thank you, Maximilian, for the contribution. And the presenter Safari mentioned about role confusion, which is an aspect where a lot of nurses find themselves in. There was someone who had asked a question regarding medication on the chat. Let me read it. I know time is past the hour, but with your permission, Moses, someone had asked on the chat, how administering medications can be dependent function of a nurse, because we nurses and doctors study the same pharmacology. Then how can we nurses follow the doctor's order on medication? I'm not sure whether the person that asked that question has gotten the clarity from the discussions, or they still need that to be kind of discussed. Abiba, your hand is up. You can go ahead. I wanted to be sure that the person who asked that question has gotten the answer from the discussions that have been done. Abiba, your hand is up. You can go ahead and ask your question. Okay. Arnold? Arnold, your hand is up. Did you have a question? Okay, Latif, go ahead. Latif? Okay, I'm trying to call out the people whose their hands are raised. I cannot.
Ready?
Yes, Abiba, go ahead.
Thank you so much for giving me this opportunity. Thank you for all the presenters who have been presenting since we start this session. But my consideration is about awareness of nurses who are on the field, I mean, who are in clinical areas. The big problem we lack in clinical areas is awareness of nurses of about their responsibilities and their duties. In this, the problem or the main root of this cause, it starts from, I mean, this school of nurses. Most of the students who are coming from schools and they are in clinical areas for teachings, most of them, they don't know what they want to do in clinical areas. So the solution for this problem, I mean, for the lack of awareness for nurses, maybe we can say those who are lecturers at School of Nurses, they have to make awareness for these students so that when they complete their courses, when they come to the hospitals, when they come to the working areas, so they might be aware of what they are going to do and with what reason they are doing what they are doing. Thank you so much.
Yeah,
Thank you,
maybe.
Abiba. Yes, go ahead.
Yeah, maybe to just clarify, sorry for the bit interference. Huyo anayesema hivyo tumuulize swali. Ni swali zuri, ni observation nzuri, lakini yeye alipomaliza shule akaripoti hospitalini alikuwa anajua kila kitu cha uuguzi? It's not true. Learning is continuous. We don't expect a person to graduate knowing everything. But at least this person knows to a certain level, na anapokwenda clinical sasa akutane na watu ambao watamenta vizuri. Tatizo ni kwamba tuna train watu, wakienda clinical wanakutana na wale wauguzi wa miaka 77 ambao wao wana a different mentality. Kwa hiyo wanawafrustrate hawa watu, hawa wanafunzi, baada ya kuwa mentor kuelekea kwenye scope ya nursing practice, wao wanafanya vile vya kwao ambavyo wanavijua. Now, for your information, most of the hospitals do not translate the scope of nursing practice into action, although the document is available. Hiyo ndo challenge kubwa ambayo hao watu wanaipata, hao graduate wapya hao. Thank you very much.
Thank you, Vincent. I would like to pose this question because perhaps in Tanzania, the processes could be different. Do all nurses get a job description that is commensurate to their level of training?
Yes. In fact, Tanzania Nursing and Midwifery Council has prepared a book that contains the scope of practice for every nurse of every cadre, of every level. Kila level ina scope yake, kila level. Sasa tatizo ni kwamba mahospitalini huko hawajaweza kutafsiri scope of nursing practice into action, na ndo kilio kikubwa. Na ndio maana sasa hivi tunatamani sana viongozi wa hospitali waweze kutafsiri scope of nursing practice ambayo imeandaliwa na Tanzania Nursing and Midwifery Council katika practice, kwamba nesi wa diploma sasa afanye majukumu yake, wa certificate majukumu yake, wa degree majukumu yake, wa masters majukumu yake. Hapo ndo changamoto ilipo. Sasa unakuta sehemu zingine matron yana diploma alafu ana watu wanaowasimamia wenye masters. Hiyo ndo changamoto inapoanzia. Kwa hiyo That's how the challenge is on implementation.
Okay, thank you very much, Vincent, for that clarification. Because if everyone practice according to the scope of practice, then there will be no role confusion. It will be very
Yes.
quite clear. We will be satisfied as nurses, and we will enjoy what we do as nurses. Thank you for
Yes.
that clarification. Someone on the chat is mentioning about the curriculum gap that stems from the teaching institution and the issue of the emphasis on the scope of practice. Thank you for that comment. So, yeah, someone asked about the issue of the job description. If all nurses are given, swali ni je, wauguzi wote wanapewa job description wanapoanza kazi? There's that question on the chat. Perhaps Vincent could respond to it. Then someone else says scope of practice hipo, ila hipo kwenye maandishi, not in action. Thank you for those sentiments. Vincent, would you like to give any further remarks? Then we can allow Dr. Walter and Safari to give their closing remarks as the key presenters for today's session. Vincent, go ahead. Sorry, I think we lost Vincent. In the interest of time, Dr. Walter and Safari, could you give your final remarks on today's discussion?
Yeah, right here, Dr. Walter, yeah. Yeah, my final remark goes to the three parts here. Yeah, the independence, but dependent, and the collaboration. You see, I always encourage and bold this, even to the level of training institution, that independence is built by yourself. No one can come and build independence for you. So we have levels and nursing profession. We have managerial level, we have operational level, and we have students who are going to care for patients. So in order for you to promote identity, professional identity, you need first to prescribe guidelines, standards, but also strategic plan that will embrace the production or development of nurses whom we want to carry the image of nursing in Tanzania or in the world. So independence is built. No one can come and build independence for you. Start structuring the framework of how nurse in Tanzania should be identified, should be respected, should be valued. Today we can talk of guidelines in clinical, whichever, but who prescribes them? Is there any creative way of collecting those who are working in training institutions, those who are working in clinical settings, and the students as stakeholders, and the other stakeholders, so that they sit together with the professional organizations, professional unions, TNMC, TANA, ZNMC, and at least have harmonized the language on the way they want themselves to be identified in the community. If there are ways that have been planned to do that. So only this strategy within this profession can make you be identified as nurses, valued as nurses by other disciplines. And then it comes to the collaboration. Collaboration is built by the patient in the clinic. Patient is the one who determines your collaboration. Whether you collaborate with medicine, you collaborate with the pharmacy, you collaborate with the laboratory. And then your scope of collaboration will be determined by the level of independence that you have, the level of autonomy that has been prescribed by your organizations, by your union. I know that we have leaders in nursing profession. Let them prescribe a clear path, a clear value, a clear identity of nurses that can be induced, inoculated in the field, in the community, so that you have positive professional identity that can be respected. And then the patient can determine our collaboration. That I am sick, I am maybe diabetic, so I need a nurse, I need the medicine, I need the pharmacy. It's where you meet together and discuss patient condition. You are going to respond to patient's sufferings. I am going to prescribe this one. You need to reason it, right? And then dependence is not like anything that you are given as an order, you go and implement it. No. Nurses currently in the 21st century, they needed to engage themselves in research. They needed to engage themselves in advancing their academic career. Not depend as I am a bachelor. You need to fight as much as you can to go further in education, because you want to promote professional identity by deliverables, not by describing, because you can say, I know what is diabetes. That is not enough. You need to bring deliverables in nursing profession. The nursing profession has given you an employment. What do you deliver for the profession? You need to ask yourself. It's where you need to find the collaborations. You need to engage yourself in research. You need to engage yourself in exchange program. I can bold this, that leaders should promote also exchange programs. If there's nurses who are working in Dodoma, they need to at least have online conferences, maybe periodically, monthly conferences, exchange program. We move here to go and Dar es Salaam to learn how our colleagues are doing there. And then last, as my closing remark, I call for those who are managing nursing education, but nursing profession, right? So that at least they establish a kind of culture which call all academic staff in training institution, clinical staff who are working in the clinical setting, students, at least to have a joint meeting, a joint exchange programs, maybe, so that we exchange what is happening and what do we want and where do we want to go. This one may clear each and everything when we talk of tasking or confusion, whichever, and then let emphasize higher learning education to nurses, so that we have adequate of them who are having advanced nursing education, for them to deliver advanced nursing practices, to demonstrate advanced nursing skills. And then these all issues may inform job descriptions or rank ya mishahara na vitu vingine. Let nursing be valued. Start yourself. No one can value you.
Thank you, Dr. Walter. Thank you for those very great and generous remarks. Moses tells me that he still has a few slides to go on the issue of unveiling the visibility of the profession. I would want to hear from Safari. Is it okay? We have Moses. Go ahead and unveil that visibility, then we can have your closing remarks after Moses does this unveiling. Moses, how many minutes would you want to take? It's 21 minutes past 9.
I think less than 10.
Thank you.
Okay. So thank you very much for taking this time to have these few slides to discuss with you. But almost as Mafata team, we have seen one of the challenge is the visibility of the profession based on the procedure that we are doing in a clinical area. And I think this is one of the big problems currently. Can we ask ourselves, how do our procedures that we are doing all the times actually reflect the welfares of the nurses around the clinical areas and even out from the clinical areas? Because I think this one is a base of how many nurses are not interested doing such procedures, and probably they're just taking a follow-up to see if they can be interested much on the other procedures, whether medical procedures or whatever, apart from nursing procedures, probably because the nursing procedures, it seems are very easy, are very normal, are very simple, that it can be killed by anyone else. So sometimes they are just moving from there. So can we discuss more? How do these procedures are visible? Whether you can see like insurance, health insurance, we're not so much recorded there, the one doing the procedures, we are not signing anywhere that we are doing our procedures. And how do now these procedures turns advantages and impacts for the nursing profession? I think this is one of the areas we can invest much of time to discuss and to see how this is problems. Because we are doing these procedures as part of creating the professional visibilities, but in reality, it is not. So as part of introductions, I want to share with you the overview of nursing profession, but this is clearly defined from the different presenters, so I can't so much focus on that. But almost important of feasibilities and welfare in nursing, basing on the procedure that we are doing, and also the rule, routines, procedures in professional development. Probably this here, there is a problem. So we have two areas to ask ourselves. How specific nursing procedures enhance professional visibilities? Because if there is no visibilities on the procedure that we are doing, then you have the problem. And because of the different levels that we have, probably some of the procedures, when they are being defined in categories based on the education level, we expect them to be independently defining the professional and the existence competence of the profession that's working on that procedure. And also to explore the contribution of nurses' welfare and recognitions. Are they, all those procedures that we're doing, are they recognized? So for example, we have some of the procedures, probably few of them, but I know that we have a lot of procedures, but few of them we can present here. For example, urethral catheterization and recatheterization. This ensures the patient comfort and bladder management. So the aim of doing this is like to enhance nurse visibility as a skilled and competent professionals. These are the procedures we are doing, but are they recognizing that we are the one doing, or even someone else can do it? So we have the time to discuss, because some of the nurses around the clinical area, they are saying that catheterization, recatheterization is very important procedures and define the clear nursing profession itself. So how do we ask ourselves, is they turns and an impact in professionals, or anyone can do it? Cannulations. This is one of the areas that is very vital for IV access and fluid management. But this is told us how we are technical competence in these procedures. But is it clear defining and recognizing what we are doing? But the other procedure that we're doing all the times is NGT insertion. This procedure is very important, and it is life-saving procedures. We all know that this is like helping in feeding and gastric decompression itself. So the aim of this is just to display the necessary ability to handle sensitive procedures as part of helping the patient to survive. And this has been referenced from the Fundamental of Nursing, Taylor, in 2018. But is it recognizing and defining the, showing the visibility of the profession or not? If yes, can we make more value to ourselves that this procedure is very important for us? For example, bed bath. This is one of the good procedures that we're doing. Is it defining clear hygiene and dignity of someone else? But this shows the compassionate nursing care. But how do it recognizing us? Are we doing now or not? And if not, why? So I think this is a clear issue that we can see. But sometimes we have some of the procedures else, like stitching, and even removing the stitch from the different procedures that have been done, whether in the minor theater or whatever. But we are doing as nurses. So are we subjected by someone, or it is a type of procedure that we can do ourselves? And if we are doing, are they recognizing or defining our professional and our welfares and development in general? Intubations, one of the procedures. Criticalness, they are doing all the times to save the patients. But intubations, one of the procedures that define profession or not. But I have some of the procedures apart from that, including medications, administration based on all the procedures, all the routes, including pharmacological and other issues. These are the issues that create even the trust in patient safety. So these procedures, clear defining the profession, but are we doing as we want to define the profession, or to create the welfare of our profession, or growth of the profession, or to show how competent we are? If yes, why are not they appealing to the different plans and documents and even practice that defines clear nursing? Because everyone, it thinks like he can or she can do it. RBG monitoring is very vital, important procedure that we are doing for the patients. Whether we do the assessment so that we can come up with conclusions. This patient is having a low RBG or is going back to diabetes or whatever. So if that is a good procedures and even the important procedure that we are doing, is it defining the clear existing of our profession? Minor and major wound dressing, how do you see? This is one of the procedures that we do, that we are very competent in surgical and wound care. But is it defining the profession itself? How the growth is it? Is where any documented that this is very important for nurses to do it? And if yes, is it making the visibility of the profession? I think that is a question we can ask ourselves. For those who are doing deliver, how do you feel in that procedure? when you implement it? Is it defining your growth and your competence? Is it defining your skills? Is it defines your welfares? Can you go even out from that procedures with happy and enjoying yourself that now I did this one? Because that is make the community visibility, but how the community is saying about these procedures around the communities. We have been kept on the different laws, courts, and even some of the words that are not good for us. We are just selling the child, we are changing the child, we are doing what and what the bad things is happening for us in terms of deliveries. But how do we feel? Is that the visibility of the profession? I think the challenge is oxygen therapy is one of the procedures, invasive procedures, drug infusions, nutrition assessment, and a meal plan for those who are having a challenge in terms of nutrition. Those are the procedures we use during the managing the patients. How do we feel? Are they defining our growth? Vaccinations as a public health and preventive care. This increasing the community visibility, but who is visible more? While these procedures we are the one doing. When you go to RCH and neonatal care, those who are doing these procedures specifically for vaccinations are nurses. Are they seen anywhere? Are they defined in this procedure? RCH procedures and CTC services. Go there. Even now in Ministry of Health, we have something called NIMAT, National Initiatives for ARTs, for the patients. We are the one prescribing those drugs at the health centers, at the dispensaries, whatever, the center that provide these cares. But how do this defining the professional growth? How do we define on this? How can we change this one into welfare so that nurses can enjoy that these procedures are ours? Those who are doing antenatal care, taking activities to save the mothers at antenatal cares, how do they define visible in their professions? Cancer screening is one of the area where you can find nurses are doing much these procedures. But how do you feel? Someone else can be defined. Right, necessary expertise, improve job certification and welfare. Are they defining so? So our take-home message. Our recommendation, policy support for nursing, roles in advanced nursing contribution is very important because we are doing these procedures. But how can we live with this procedure that we are defining as professional growth itself? So we have to do this one. For those who are doing policy making, we have to fight against the policy to stand our procedures, to make our procedures cloud that defines clear our professions. If we are not doing that, the policy always can be benefiting someone else. Training and continuous profession, that those who are doing training at the institutes, how do you feel? These procedures we have been taught in the class, based on the principles, whatever. But when you come to the clinical area, it seems like a normal procedures. We are doing like a routine. And even seems anyone can do it. That's why some of the hospitals even employs even the medical attendant. And they are saying that this one can do activities like a nurse. So there is no problem. Others, they are saying that we don't need to employ even the nurses from diploma level or bachelor levels because the EN can do all the activities. But how do you feel? So the procedures are now, it's like zimerahisishwa kuonyesha kwamba anyone can do it. Community sensitization, the community is still not having the challenge that nurses are doing.
Moses, are you still speaking? Moses, are you still speaking? I want to believe that Moses was on his last slide. I cannot hear him. Moses, are you still speaking? Okay. Thank you. Mr. Safari, would you want to give your final remarks as we wait to get Moses back? Safari?
Yes, thank you. I'll say a few words. I would say knowledge is power. If you are knowledgeable, you won't get difficulties in doing whatever you want to do.
You can continue, moderator. You can continue.
So, educated nurse in a clinical setting who knows what she wants to do in a professional way will not have any difficulties whether dealing with the doctors or whoever comes around during clinical practice. So she knows when to become, this time is for being me independent, and I can do this on my own or by assisted by another nurse. She knows that at this time I have to collaborate with other team for the sake of the patient. For example, during rounding, we need the multi-professionals so that you can have something good for the sake of our patients. But there are other procedures of which will need to be directed by, not instructed per se, but like Dr. Bankania said, a doctor can prescribe or can perform a certain procedure, an invasive procedure to the patient, but he cannot do it alone. You need an assistance from a nurse. So what I'm trying to say is, if you know what you are supposed to do, you won't get difficulties in performing whatever you want to do in a professionalism. Like I said, knowledge is power. Watu waende shule, wasome kwa bidii, kwa sababu it's us who are going to lift our profession to the highest level. No one else is coming from heaven or Europe, whatever, to make sure our professional is ina meet zile standards za kimataifa. Dr. Walter alikuwa anazungumzia kwamba kumtengeneza mguu ambao anaweza katoka hapa nje ya mipaka nia akawa katika level ya U, if possible, ni sisi wenyewe tu. So that's all I wanted to say. Thank you.
Thank you very much, Safari. I totally agree with you. As long as you are competent as a nurse, as long as you know your staff or your area of specialization quite well, you will begin all the way from the most basic, like vital signs taking, to the greatest of interventions that your scope of practice allows you to do, and everyone will just respect it. Thank you very much for those remarks. Moses, I can see your slide still on. Do you have any final remarks? And please, I would like to hand it over back to you for the closure.
Okay. So can I say something?
Yes, please, Moses, take it over and go all the way to closing the session. Thank you.
Okay, thank you very much. So as I have said that we as nurses and also leaders and also the one who taking the training, who supporting those young generations that are coming in the street for the work, I think you have responsibilities of recording ourselves and working on this. Policy support for nursing laws and the advanced procedures. As we know that we are doing a lot of procedures, but those procedures are not so much defined anywhere. to keep our professional growing. So I think there is a challenge in terms of policies. So if we can advocate ourselves much on policies, will help us to make those procedures visible, and probably will be visualize our professional as much as. But almost even those who are taking training, they should continue charging, helping those generations into professional development, because they have to go out while they know how to make their procedures visible and visualize the professionals as much as they can, instead of coming in the clinical area and taking time to see those procedures are normal, usual, and routine, so everyone can take them. More nurses, probably you can take this as one of the area of advance. Yeah, sure. It is very clear demoralizing, and it is clear making pain for some nurses, because they're not enjoying profession at all. Because when they come in the clinical areas, we have a lot of words that are coming, because they are saying, some of them, they are saying these procedures, even the medical attendant can take them. These procedures, even the EN herself or himself can take them. But this one, so I think there is a challenge here. And also the final in the community sensitization on nursing contributions, I think should be done accordingly. The community do not know exactly that those procedures that we are doing to help them to remain safe, they think that those procedures, we are not the one doing them. So how we can define them, probably we can incorporate them into different the plans and even the policies that can make us to be more visual in terms of this practice. I think this was the issue that I want to emphasize much on, basing on the procedure that we are doing. We can make those procedures to be more visualized by everyone, to see that this is a very important and necessary they are taking them. Thank you.
Yeah, maybe Mr. Moses.
Yes, Chief.
There is one thing maybe we need to discuss as a challenge. When we are speaking of nursing, we do not speak of nursing. We not measure nursing in terms of single procedure. We do procedure to answer specific nursing diagnosis. And those diagnoses comes from the assessment. So that is something ambayo lazima tuijue. Lakini cha pili ambacho tunatakiwa kukijua na ukitafakari ni kwamba hii nursing profession inachezewa tu. There are people who play with this profession, ndani na nje ya profession. Hello? Can you hear me? Hello?
Yes, we hear you.
Chief. Endelea.
Yeah. Okay. Kuna watu wanacheza na hii profession ndani na nje ya profession. Huwezi kuniambia kwa mfano procedure ya uuguzi kwamba anaweza akafanya mtu yoyote ile. Awe anaweza, awe hawezi. That's none of my business. Medicine, wakati nasoma history of medicine, kabla medicine haijawa medicine hii ya modern medicine, operation walikuwa wanapasua brain za wagonjwa, walikuwa hawajui hata kusoma na kuandika. As we speak now, there are people who are performing very serious procedures na hawana hiyo shule. But that does not remove the fact kwamba hii primarily ni procedure ambayo professional ameisomea ndiye aifanye, kwa sababu we believe huyu mtu ana knowledge ya kutosha na ana uwezo mkubwa wa kufanya hicho kitu katika professional way, not just doing. Mimi niwaambie ukweli, the simple procedure of blood pressure measurement, nikikueleza kwamba tukisema tu assess kihalali, professional wa madaktari wa uguzi, unaweza kukuta less than 20% ndio wanaweza kufanya hiki kitu katika standard ambazo ziko prescribed. Na kuna wengine unamfundisha mwanafunzi standard practice ya kupima blood pressure, anaenda clinical, anakutana na wauguzi na madaktari wanawafundisha vitu ambavyo ni nje kabisa ya standard practice. Kwa hiyo tunachozungumzia hapa ni swala la value ya ile quality ya procedure katika kusevu maisha ya mgonjwa, not just doing. Kwani kupasua tumbo, kila mtu anaweza akapasua tumbo nani, lakini what will be the outcome? Tunachoangalia sasa, anafanya professional kwa sababu amesomea hicho kitu, na tunaamini kwamba atakapofanya hiyo outcome yake itakuwa na more therapeutic outcome kuliko ambaye angefanya mtu ambaye hajaenda shule. Kwa hiyo mimi ninapokubaliana na wewe tu ni kwamba namna gani procedure hizi au kazi za kiuguzi zinakuwa translated kwenye policy. Watu wanaoichezea hii profession wanachokifanya, wanataka kuionyesha nursing profession kama is just, unajua nursing profession ndio 60% ya workforce na ndio wanafanya 80% ya majukumu katika Wizara ya Afya. Lakini hawa wanaofanya 20%, nguvu yao ni kwamba wanatumia politics na wanatumia ile influence kwenye leadership kutaka kuionyesha nursing kama ni kitu kadogo ambako mtu hata ambaye akwenda shule anaweza kufanya. Ile ni kupotosha mfumo kwa maslahi yao binafsi. Na hii imesababisha wauguzi wengi kuwa passive na wagonjwa wengi wanakufa directly au indirectly kwa kukosa quality nursing care, kwa sababu wauguzi wenyewe wanajiona wako passive. Na therefore they don't play their critical role they are supposed to do. Nenda leo itembelea hospitali za mkoa. Kuna wodi ambazo hazina hata vifaa vya kupima vital signs, hata BP machine hamna. Na wauguzi wako comfortable. Lakini vital signs ndozi, kwa sababu moja ya kazi ya uuguzi ni kumonitor afya ya mgonjwa hapo kwa clinical. Vital sign measurement ni moja ya monitoring, kwa sababu una measure na kuinterpret na kutake action. Lakini utakuta hakuna, na wauguzi wengine kwa kuona umuhimu mdogo wa hicho kitu kutokana na akili zao wanafoji mpaka vital signs. Kwa hiyo ndio maana tunasema whether watu wanaiona ni swala la sisi tunaiposition vipi uuguzi katika translation of policy and practice. Lakini kwa maana ya kusema kwamba sijui nani procedure hizi kama, hakuna cha common. Common ni kwa professional, sio kwa non professional. Ni hayo tu nilitaka kuongezea. Asante sana.
Is Moses still with us? Okay, Vincent, would you take over the session? I can't see Moses. We could just wind up. It's 46 minutes past the hour.
Okay, we see some few hands. I don't know. Maybe we can just allow people to type in their questions and maybe to share with Mr. Moses, so that they can be shared through the handouts and some short leaflets. Otherwise, because of this time we have, maybe we will end up this session. Because sasa hivi ni saa 4 kasoro na tumeanza saa 2. Nadhani tumesha discuss vya kutosha. Na maswali ni mengi, concerns ni nyingi. Watu watawasiliana na Mr. Moses alafu wataweza kushare kwa team. Kwa niaba ya team naomba niwashukuru sana washiriki wote kabisa, kuanzia presenters Dr. Sixtus Ruyumbu, Dr. Walter na washiriki wote na moderators. We have Miss Faith Sila. Thank you very much for your good moderation. We highly appreciate. Lakini pia tunashukuru sana wote waliouliza maswali na kutoa michango na maoni. Kwa kweli yamekuwa very constructive na tunaamini sasa hii imetupa chachu ya kwenda kusoma vizuri zaidi. Kwanza tuelewe uuguzi, lakini mbili tujue nini tunapaswa kufanya tunapokuwa katika stesheni zetu. Ni aibu muuguzi uwe hujui unachotakiwa kufanya na umemaliza diploma degree on the bedside. Yaani unakea mgonjwa mwenye malaria au mwenye hypertension, mwenye kisukari, alafu hujui unatakiwa kufanya nini, wakati vitabu vya uuguzi vya medical and surgical vimejaa, material yamejaa, kwenye simu yamejaa, yanayokuelekeza nini unatakiwa ufanye kwa huyo mgonjwa. Nursing care plan zipo, mpaka standard nursing care plan, nini unatakiwa ufanye. Sasa nafikiri hiyo ni changamoto, tukasome zaidi, lakini pia na tunaamini katika grupu hili kuna watu wa policy and practices huko, nadhani nao watachukua changamoto zinazogusa policy na local practice supervisions, ili nao wakatusaidie katika haya maeneo ambayo yanawahitaji. Vinginevyo niwashukuru sana na niseme asanteni kwa niaba ya Multifaceted team, kwa kuwa Moses sasa naona Mr. Moses naona amerudi, labda nimrudishie sasa yeye kama kuna lolote, alafu atufungie. Karibu Mr. Moses.
Okay, thank you very much. I had a challenge on network, so I'm back again. Naomba nitoe shukrani kwa watu wafuatao. First of all, I want to congratulate and appreciate all presenters, Mr. Sixtus Safari together with Dr. Walter Milanzi. Wametulisha vitu vizuri sana, and we're very happy for that, and I think vinatujenga, and from here now onwards we can take a time to change ourselves on the different perspectives and areas of improvement. But almost even most appreciations goes to our moderators of today, Dr. Vincent Bakanie, together with Madam Faith Sila from Kenya. Actually, we enjoyed the sessions. You did your well moderations and smooth moderations, so we have been exhausted a lot. But thank you very much for all participants that have been joined together for these sessions. Actually, we have enjoyed together with you, and I think everyone has enjoyed. But almost even thank to Multifaceted team for your contributions and for your presence. Finally, I have few issues to say before say bye to you. One, as Multifaceted, we expect to have a research training program that have been registered by Tanzania Nursing and Midwifery Council. This training on research will be starting from June, and this time around we are just having a registration, and the link is open through Multifaceted Academy. And the second portions, we have created this platform, Multifaceted Academy, that is for selling and buying professional materials. So we think this academy will help everyone, because you can register as a student, you can register as an instructor, you can register by whom and you can upload your course. You can just take enrollment of the students there and monitor their performance, accomplishment, assignment, assessment, everything. Now you can publish your books, you can publish your article, and you can make for free, you can make for premium, and all the months you can receive. So this academy is a revolutionary tool for everyone that can benefit from it. And those research packages we have already attached there, so everyone can access them. So tunawashukuruni sana, tunawakaribisha kwenye hii academy. Kwa sasa tunaanza na matangazo ya hiyo research program ambayo inaanza mwezi wa 6. Na one of our facilitators mojawapo wako humu, like Dr. Milanzi, ambaye amewekeza kwa kiasi kikubwa kwenye research na atakuwa mojawapo kati ya facilitators wetu. Kwa hiyo tunawakaribisha sana, tutaendelea kushare matangazo pamoja na ninyi, lakini pia session za kila mwezi zitaendelea. Kwa hiyo this time around tunaangalia session ambazo zitakuwa ni useful na clinical based presentations, ili mwisho wa siku tuweze kusonga mbele pamoja. Baada ya kusema machache, naomba niwatakie kila laheri, na kama hakuna kingine cha ziada, basi we can have a time to rest and to make ourselves waiting for tomorrow to go for church. Thank you very much, and I wish you all the best and have a good night. Yeah, thank you very much. Materials will be shared. Materials will be shared. Thank you, Dr. Bankani. If you have something to say before leaving the place.
No, I have nothing to say, but only to insist kwamba wauguzi tusome kabisa. Hilo ni la msingi sana. Kama tutakuwa na knowledge ya kutosha, itakuwa ni changamoto. Na mbili, tuhakikishe kwamba tunapokuwa kwenye local working places tuna demonstrate, tuna translate the knowledge into practice.
All right.
Thank you very much.
Thank you very much. Dr. Walter, you're welcome. Chief
Yeah, I
Nelson.
wish you all the best. I wish you all the best. Good night.
Thank you very much. Have a nice night, Chief. And all of us, let's have a nice night.
Thank you very much.
Thank you very much.